Hello, for those that don't know me, my name's Catherine. I'm one of the Paediatric Emergency Medicine consultants from Leicester Royal Infirmary. And I have been asked to do from the finger to the forearm. So I've got a series of X-rays and cases for various different bits of the body from the fingers to the forearm. And the first one is on the opening side. So this is one of those things that that just reminds you that minors isn't just about injuries. It's not always minor and it's not always injuries. And I just wanted to start off with this side because it is an interesting X-ray. Can anybody tell me what it shows?
Yeah, somebody's put radio-ulnar stenosis.
Oh, well done, Mahmood. Yeah, so yes, so it is literally, it's one of those things that it looks really complicated, but it is literally say it how you see it. So the radio and ulnar are joined together. And when that's a bone, you sign, and osteosis means growing together. So the radio and ulnar have grown together. So this kid had pitched up not being able to use his arm properly, and they weren't sure why. It turned out that probably was quite a long-standing problem, and he just couldn't pronate it properly. And the reason was because actually he couldn't physically do that. So yeah, so I just thought I'd start off with that one just to remind people that it's you can see anything. Okay, so the things I'd really like to talk through are things about what not to miss, things about what to treat. Remembering that minor injuries are injuries that can be treated relatively easily, but if they're poorly treated can cause lifelong problems. So I think we kind of always tend to think of medicine in the context of where we are now, but just remember that, you know, the last 150 years, these are things that we've learned how to do. We've learned how to manipulate fractures the right way. We've learned which ones are important and which ones aren't, and we're still learning. So it's really important that we see minors in the context of the whole patient. The upside of it is actually a lot of stuff will get better by itself, and a lot of the research that we're doing at the moment is focused on, well, actually, are there things that we can leave alone? Do we actually need to interfere with all of those things? And so that's going to be a bit of a theme of this talk as well. And just remember that, unfortunately, minors is something that can generate lots of claims and complaints. So it's really important that we're quite thorough in our assessments. So, fingers. What is important in a history? Now, again, it's fairly obvious. So it's how they did it and when. So was it today? Was it yesterday? You know, in terms of looking at how much swelling they've got, whether they're right-hand or left-handed. Everybody talks about this in the context of adults, but remember, all children ideally are going to grow up to be adults. So they may not be a plumber now. They may not use, have a manual occupation now, but they might do. And certainly most people are going to need to type and text and use small electrical implements, and that requires good manual dexterity. So thinking about that when you take the history, was it a crushing injury? Was it a hyperextension injury? Can anybody tell me what kind of fracture is on this X-ray? Hi Sophie. Yeah, you've got a little tough fracture there. It's quite an interesting one because it's a longitudinal fracture all the way through the distal phalanx, and that's slightly unusual. What kind of injury causes that type of presentation? A door, yes, Jen. Yeah, a crush injury. My brother-in-law taught his children about this by getting carrots and slamming the door on the carrots so they could see what would happen to their fingers if they got them stuck in the door. And although I think that's a bit harsh, it certainly was effective. But yeah, so doors are classic. Car door, and just also remember which side of the door it was and whether it was a heavy door. What other things might you need to think about with a crush injury to the distal phalanx like this? Yeah, so nail bed injury, and whether you need to treat this as an open fracture, because actually that's quite a large fracture in terms of the amount of the finger that's broken. So you would want to think about infection and whether you need to treat this as an open fracture if there's a wound overlying it. Okay, so one of the things that with the examination, obviously you'll hopefully notice if it's bent or partially missing, and that you probably don't need to explain to you. But the really important thing to not miss is rotational deformity. Does anybody know why that is? Yeah, Nadia, what kind of problems can it cause? Yeah, so it's functional. Yeah, so function. Yes, functional to do with grip. So essentially, although they often look worse when they're twisted or bent the other way, if you've got a rotational deformity, that's the problem. The thing that's most likely to cause you a problem in terms of going about your day-to-day activities. And so that's a really important thing to miss. Partly, not to miss, partly because it's more subtle, but also for the patient, it's more significant. And so I'd really encourage you, when you're thinking about your examination, to really assess whether they've got rotational deformity. It can be a little bit difficult because obviously in this picture, this person can move all of their fingers fully, so it's easy. And I think when you've got somebody who's really declining to move their fingers at all, it can be a little bit more difficult. But what are the strategies you could do to overcome that? Play, yeah. Yes, so I suppose what I'm saying, Sankaran, is that if you can't get them to align their fingers because they're not moving their hands, that's the problem. So how could you overcome that, so you could get them to move their hands a little bit more? Yeah, analgesia, yes. Analgesia, yeah. Analgesia is key. So if you're ever struggling with examining children, then analgesia is really important. We really do tend to under-analgesize children, and please don't hesitate to do that. Yes, distraction is really helpful, and play is really distractional and really helpful, and that may be enough. But analgesia is key. And the other thing is to use their other hand. And if you can see it's different. I know this sounds really obvious, but if you've got two of something and they should be the same, if they're not the same, then you have a higher measure of suspicion. But yeah, so that's really important, not to miss rotational deformity, and it's probably the most important thing, really, because they may need operational management in a way that you might not think they do in X-ray. It's so important that the orthopods have actually put it on the fracture clinic referral form in our hospital, and that's why it's there. That's something they genuinely want to know. Okay, so what if it is missing? Like I said, that's usually fairly obvious. Can you stick it back on, and do you need to? So those are the two things. So is it possible, and is it worth it? If it's just the pulp of the distal phalanx, usually those heal very well, particularly in young children. So when you're talking about you've got a tiny little finger with an injury that's proportionally, they've lost a lot of tissue, or it looks like they have, then actually you kind of think, well, that probably will heal quite well. It might take time, and that you need to counsel the parents. It might take time, but it usually will heal very well. Obviously, if you can see bone, then that's a bit of another issue, and whether the bone is intact as well. That's the other thing. Is the nail bed intact? And if there's any doubt, do take some photos and ask a senior. So when I say take photos, particularly in Leicester, so we can take photos that go into our hospital ED system, where both the plastics and the orthopaedic team can look at those photos. So it's not just about the senior who's maybe at the other end of your department who can see the photo, but actually anybody from the team can see the photo, and that's really useful. Partly if they come back later on and you want to see how it's healing. What I'm not advocating is taking photos on your own devices. No, and that clearly is an information governance thing, but for us in our department, we can take photos with our devices that we use for doing OBS, and they go on our hospital system, and that's really, 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 really useful, and the whole team find that useful. So I would say, particularly if it's not a controversial body part, then taking photos can prevent re-examination. Okay, so what if it is bent? Okay, so if you see a finger that's bent, you take an X-ray and it confirms that it's broken. What are you guys thinking? So yeah, so think like an orthopod. If it's bent, fix it. Like if it's bent, you can fix it. Yes, okay, so there is a little bit more complexity to this. So while I want you to think like an orthopod, I also want you to think like a paediatrician. So do they need analgesia? And the whole kind of which analgesia you use is is debatable and should be it should be part of a patient-centered question and should be led by the patient. So you can ring block them, and depending on the age of the child, that may or may not be well tolerated. And I would certainly advocate for having a discussion with the patient about how they want you to do that, whether they want the injections, knowing their finger will be completely numb, but the injections are painful, or whether they want Entonox and fentanyl, knowing that they may experience some pain, but they won't have an injection. Those are definitely a discussion to have. The question about can you fix it or do I need help will be a little bit about where the fracture is, how many bits it's in, and how angulated it is, because you may not be able to pull that with just a little bit of Entonox, and you may not be able to pull that with a ring block. Particularly, so some fingers are bent, it's actually the metacarpal, and the metacarpal's gone in, then a ring block isn't probably going to be effective. But you definitely should think about reducing these in ED. It's not such a big job, but for most of them, it's not such a big job that they need to go to theatre. So, and it's also fun if you're thinking about, what makes your job interesting. Getting hold of things, fixing them is definitely part of what makes our job interesting. Again, what I'm not advocating is just having a go by yourself. If you've never done it before, then yes, get a senior support, but do think about it. Don't necessarily refer straight away. This is potentially something that we can do off our own bat and get the patient home relatively quickly. Depending on the age of the child and their tolerance and everything. Get the play specialists involved early. I mean, a bent finger looks quite scary, and so it's about enabling them to cope with all of those things as well. But yes, Alex, what Alex has said is, does the patient have enough analgesia? Can I fix it, or do I need help? Those are the questions you should be asking yourself. Can we do this? So then just a little bit of basics. So how do you store amputated body parts? Obviously not in bread with ketchup. That's okay. Some ice. Yeah, that's part of it. Yeah, not directly on ice, wrapped in a big plastic bag in cold water ice and in ice. Okay, so wrapped in a saline soap gauze, okay, inside a bag, inside another bag, which is filled with ice and water, which is labelled. And I'm make no jokes about this. Somebody within the recent months found a bit of somebody's finger in our fridge, which was unlabelled, and we weren't sure how long it had been there. So please do label it or keep it with the patient. So if you're going to put it in the fridge, that's not an unreasonable thing to do. But please do make sure that it's absolutely clear which patient it belongs to, because otherwise potentially it could go missing. Yes, it is horrible. Yes, so as short as possible is the answer to Sankaran's question. How long can we keep what time to fix the amputated part back? I mean, it's hours really. So people say around 6 to 8 hours, but the shorter it is, the better it is. So you want to, if you really think it can be stuck back, then you want to get plastics to see them as quickly as possible. And again, photos are really helpful for that. It can be quite difficult to write. And again, I don't know, every hospital has different policies, but we do all our referrals to plastics and to orthopedics via e-referral, which means you have to type something in quite a small box. So photos do speak 1,000 words, and if you've got ways of, again, with our information government perhaps on safe ways of getting photos to your teams, then that's a really important thing to do, because it's just so much easier for them to see. I know, I got it. Yeah, I got this from a Halloween recipe website. It looks quite easy and quite fun. But anyway, that's this is the thing. And it's not long till lunch, Harpreet. So nail bed injuries. Now, if I was going to say one thing, a lot of them get better. One of the things that we find in our department is that these are kind of automatically referred on. they don't all need repair unless they're complicated. So, you know, if they're a simple laceration, it's going to heal, it's a cut. You don't necessarily need to stick that back on. If you've got a complicated nail bed of laceration, or you've got a fracture underneath, then it's a completely different kettle of fish, but they don't all need repair. And again, what I'd encourage you to remember is thinking about the patient journey. If you refer a lot of things that actually don't need doing, what you're waiting for is an opinion from somebody who may not be more senior to you than yourself. And this is not me being patronising, but I was that orthopaedic F2. I had no orthopaedic knowledge or no orthopaedic experience. And so when A&E used to call me down to review somebody's hand or whatever, it's like, you know, to be honest, my opinion really wasn't worth having. And so you just need to bear that in mind. If you need something done, and you're certain you need something done, then that's fine. If you're not sure, then ask somebody next to you, do you think I should refer this? And if you think it will get better, then, you know, again, pictures, just ask a senior. And the pictures for these things are really good because they often look quite grotty, these things. And again, you don't want to traumatise the children by keeping on opening up their bloody, grimy dressing that somebody's managed to stick on in the playground. You really do want to think about just leaving it alone as much as possible. And again, I can't speak for all hospitals, but our HCAs. So what I'm saying, Sankaran, is no, it definitely doesn't always need suturing. No, it's a flat no. So it does not always need suturing. In fact, most of them don't need suturing. So what I would say is, if you've got a complicated laceration that's extending in multiple different directions, so it's cutting across the cuticle, that's clearly damaged where the nail bed is growing out of, then you'd be more likely to consider repairing that. If you've got a simple cut across the nail bed, with a nail that you can kind of either use to splint that, or a nail that's completely off, then actually, you know, that if you had a cut like that anywhere else, you wouldn't necessarily suture that. You just make sure it was all tidy. So you don't necessarily need to suture them all, and the evidence is that most of them will get better. You can, however, stick the nail back on so that you protect the growth plates of the nail, and that's quite a useful thing to do. So that's something that's worth considering, especially if the nails kind of come out to the growth plate. That might need tucking back in, and that is uncomfortable. And again, it's about how you manage that as a pain relief. But what I'm saying is they don't always need suturing, no, and that's why you don't need to refer them all on. Does that make sense? Does anybody else have any comments on that? So technically, so according to our protocol, you can't, because it's a distal bit of that. So Harpreet's asked about that gel. So for people who aren't familiar with that, it's great stuff. It contains lignocaine and adrenaline and a stirred anaesthetic, which I can't pronounce, beginning with T, and it goes on wounds and anaesthetises them really, really nicely, and you can suture them, and then you don't need to have an injection to have local anaesthetic, which is fantastic. But actually, because it's got lignocaine in it, technically, because the nail bed is at the distal end, you probably shouldn't use it, and I think it's against our protocol for that gel to use on fingers. So yes, so theoretically, no is the answer. Okay, so metacarpal injuries. I'm not going into too much detail about this, but just thinking about teenagers expressing emotion. Quite often, teenagers who are stressed out will punch things, and some of them, as a way of venting, will punch things that aren't people, so they don't punch people. And that's great for everything except their hands. Can anybody tell me, aside from the risk of sustaining a fracture, why punching all of those things is different? And it's the snowman, not the kid. Punching the snowman poses no risk at all. Okay, so all of those are valid points. I'm going to just scroll up in the chat so that I can take them one by one. So fight, biting, punching somebody else. I'm hoping you're familiar with this as a concept. So the human mouth is dirtier than any other kinds of mouth. Unfortunately, we are filthy animals. And so what can happen if you punch someone else in the face, their teeth either accidentally or deliberately may puncture your skin. And what you can end up then is a highly contaminated wound right over a tendon sheath, which is connected to all the other tendons in your hand, and you can rapidly develop quite a nasty infection. So if you've got a fight bite, that does need antibiotics. Okay, so a fight bite is a accidental, deliberate bite to the hand after you punch somebody else. And I would be really, really cautious and actively explain to people and ask them how they sustained, their knuckle injury, and be clear that you want to know whether they've got a fight bite because of the risk to them, not because you're it's not a judging thing, but actually is a real risk. So surface shape, surface tension. Yes. So so the second point is about the self-harm and the pain. And again, I'm totally up for teenagers punching things other than people. That's a good thing. However, what needs to be differentiated is are they using it as a form of self-harm? Are they using it to control their emotions? Is there a background emotional problem that needs some investigation, that needs some management? And just again, thinking about that, I know that when I get angry enough to want to break things, it's usually because there's something significant that's happened to me, and we just need to be aware of that. Again, I'm not sure where you're from, but we do have like a violence intervention team. So if people have been involved in violence, and if they are expressing themselves violently, then actually that team might have a role to play in that, and that's a really useful thing. Jane has accidentally shouted at us, but yes, so you're thinking about how much force they put into it. Do we actually need to look further than just the knuckles, and maybe x-ray the wrist as well? That might be, especially if they've really properly punched a wall. And yeah, so and in terms of the kind of physical abuse, it's about why are they in that situation. So if they have punched another person, the whole thing about it taking two to tango, it's like what has caused that situation? What has led to that happening? So is there bullying going on? Are they the bully? And again, I don't know other people's violence intervention teams, but most violence intervention teams will spend time with both victims and perpetrators, and again, referring those children on is really important. For us in our hospital, it's an email, but it's good to have a look at your local protocols. Again, thinking about the practical points of metacarpal injury. So thinking, have you got a wound? Is the wound over the fracture? So if you punch a wall and you've got a mid-shaft metacarpal fracture, but you've got a grazed your knuckle, then that's not an open fracture, because the wound is not in line with the fracture. It's not over the fracture. If you're certain that that's not a bite, because remember, you can graze people's teeth. So if you're sure it's a wall, give it a good clean and treat the fracture. And again, thinking about the same kind of things with finger injuries. Is it bent? Have they got rotational deformity? Is there anything else we need to consider? Most of them will be treated by neighbour strapping, and that's fine. However, you might want to think if you've got a really nasty injury. So, for example, if you've got several metacarpal fractures in a row, then you can't use body strapping, because you're strapping everything to something that's unstable. So you might think about a gutter sab. You might think about getting some orthopaedic input on that, just because that is a little bit more complex. Has anybody got any questions or comments about that, or anything they're curious about? Okay, so somebody has sent me a direct message about which people to X-ray. Okay, so this is interesting, because obviously we all work in different environments, and so for me, this is not something I spend a huge amount of time thinking about, because most of the time I can just X-ray people, and even thinking in terms of the patient journey, it's often like 10-20 minutes to get an X-ray, so it's not a huge amount of decision-making power. For me, if you've got an injury where there's just bruising, there's at least some movement in all aspects of the fingers, and we'll go to talk about wrists later, and there's no obvious deformity, And then there's going to be very limited harm in watching and waiting, and you can always buddy strap it and see what happens, because actually if it is a broken finger and it's not deformed, all you're going to do is buddy strap it, and that's absolutely fine. And that's actually true of metacarpals as well. So if you've got a bruised metacarpal that's not, you've got a fractured metacarpal and it's just bruised and there's no deformity, and you were to not x-ray it straight away and you were to buddy strap it, that would be fine, because actually you know, all you would do is buddy strap it. So we get a lot of parents come in and say, oh, they bent their finger back yesterday, it still hurts today, and that's, you know, so we brought them in, and that's a perfectly legitimate decision, and I don't think anybody would have any problems with that as a decision. Does anybody else have a different point of view on that? Okay, so the wrist. So this also comes to a little bit of Kim's point. So the wrist, what are people scared about in the wrist? What can happen? So it's really interesting, because as medical students, we spent absolutely ages looking at the bones of the wrist. And as a paediatrician, one of the problems is they're not really there. So the chances of anything significantly bad happening to those bones is fairly insignificant. So obviously, some people have a lot more. Some people are worried, and we'll talk about all of those things in a second. So one of the things that people are always worried about is the scaphoid fractures, and so I'm going to spend a little bit of time talking about who you need to worry about scaphoid fractures in, because it's one of those things that we're taught you mustn't miss a scaphoid fracture. They're a danger from non-union, and you can get permanent deformity, and again it causes lifelong problems. Now all of that is true if you have a scaphoid. If, like this little chap, you don't really have a scaphoid, then it is quite difficult to break it, and so under the age of 10, you do not need to worry about scaphoid fractures. Now that doesn't mean that you don't need to worry about other things, but a scaphoid you can rule out. They're very rare under the age of 12. So unless you've got a really high suspicion of a scaphoid fracture, or looking at their X-ray, radiologically they're already kind of going through puberty, because everybody's different, then you would have a lower threshold for thinking about a scaphoid fracture. I'm going to answer everybody else's questions in a second, but do people know what are the things that you do to help you form suspicion about have a scaphoid fracture from an examination point of view? So telescoping the thumb, so pulling it out. Somebody else has written axial loading of the thumb, which obviously you would do at the same time. Examining ulnar deviation, because that puts pressure on the scaphoid. And you've got the anatomical snap box to feel if there's tenderness there. The important thing is that actually that tenderness by itself is not by itself indicative of the likelihood of scaphoid fracture. So if you've only got that, then it is very unlikely you're going to get a scaphoid fracture. It's very unlikely pre-pubertally, but when it does happen, it tends to be, so the peak in children is 15 years old, and it tends to be 15-year-old boys, because boys do the more risky things and they get all fractures. But so if you've got an older boy who's got pain on all of those things, and you have a high, and you've re-examined after analgesia, then it is totally appropriate to treat as a scaphoid fracture. But you don't necessarily need to worry about everybody. It is very unlikely on the whole that they're going to have a scaphoid fracture. And so in terms of things that you need to worry about, that's fairly low down. So what other people have put, so people who are worried about things, so missing a growth plate fracture, so a Saltaris 5 fracture. So this is a bit difficult in terms of it does because there is some subtleties here. So on the whole, Saltaris 5s are A, incredibly rare, but B, they're incredibly painful. So if you've got pain and swelling out of all proportion, then you might think about a growth plate fracture. However, what we also have is a lot of children with interesting responses to pain who will hold their hands in a very abnormal way and basically basically have a functional element to their pain, even directly after the injury. And so you have to be really careful with those, because if you reinforce that kind of injury model, it actually prevents them from getting better. So it's really important to think about that. But actually, Salter-Harris 5 fractures are really, really rare. And you think about the mechanism of the Salter-Harris 5 as a direct compression to the joint. So you need to have a really good going bush injury. And to be honest, when that happens, generally they just break properly higher up. So that's pretty unusual. So I don't think you need to worry about that too much, Lisa. Again, neurological damage is relatively uncommon unless you've got huge amounts of swelling. Parents do worry about deformity, but if you've not got any deformity, then you don't need to worry about it. If you have got obvious deformity, then clearly you need to X-ray and you need to look. And that also comes back to Kim's question of which of the risks do you not need to X-ray, or which of the risks is it going to do any harm if you don't X-ray? And the bottom line, if it's not grossly swollen and deformed and you miss a buccal fracture, then probably it's not going to do them any harm. The official thing is that we put a splint on. That may well change, and the direction of travel, and let me be absolutely clear, this is not yet backed up by the full range of evidence or within the guidance, but the direction of travel is to do less and less with risk factors. So again, Kim, if you had a kid who you said, wait and see, if it still hurts tomorrow, we'll X-ray it, or get an X-ray with your parents, that would be completely acceptable. And we see a lot of kids with buccal fractures or even greenstick fractures coming back the next day saying, oh, I put them to bed, but it still hurt, so I brought them in. And you think, actually, that's a completely reasonable thing to do. So you're pretty safe there. Obviously, if it's clearly bent, then that's another issue altogether. So we talked about this. So they may not be seen on the X-ray. They require a discerning examination, and they can heal badly, not at all. But they're almost never less than 10, rare less than 12. PKD cases 15, a Bushin male. So unless they're skeletally mature with a clear mechanism, so that may require an X-ray to kind of work that out. But if you can't see it and actually it doesn't look like that it could, then you're probably again pretty safe. So who are you going to pull? So again, in our department, we usually have the facility to offer ketamine sedation to children and manipulate arms within the department. So having a look at these X-rays, what would you consider manipulating and what would you not consider not manipulating? And what would be your reasoning behind all of these things? And I know some of you are thinking this is an orthopedic decision, and yeah, it may well be, but there are things that you're going to say, oh, I'm not letting you pull that. And there are things that you're going to say, oh, I think we really should do that. There's things that you might put a cannula in before they get there, so they're all ready. And there's things that you would, mention to the parents, maybe I think this needs to go to theatre. So just so remember, the upper right is the same as the lower right. So it's the same X-ray, it's just a different angle. Yeah, so the degree of angulation and the clinical deformity is important. So it can be a little bit difficult if there's not much deformity. When people talk about the degree of angulation, is there a number? Is there things that impact that number? Yeah. So yes. So completely right. So the acceptable angulation does decrease with age. So the classic cutoff is 10. That's the one that we kind of tend to use in our department. But again, you might get a 10-year-old who clearly is nearly fully fused, and you might get a 13-year-old who clearly isn't. But the lower the age, the better, because children are going to grow. Anything less than 13 may remodel, and again, the direction of travel will probably be to pull less and less of these, either in theatre or in the department. The neurovascular injury is interesting because I have mixed feelings about this. Yes, you want to manipulate early, but actually, if it's an injury that's so bad that it's causing neurovascular problems, possibly you might want to do that. So we don't have. Oh, I'm sorry, I completely forgot the word. The thing that you can use to take x-rays as you pull. We don't have that. So some of those fractures that are really, really nasty, that you think, right, this needs pulled as soon as possible, actually might be better off going into theatre. And so then it's about having a discussion about the risk benefit for all of those things at a fairly senior level, and getting the orthopods to engage in that discussion. And increasingly what we're finding is that the orthopaedic consultants are having having sensible discussions with us about who they want to pull, and the bottom line is it's their patient. So if they want to pull that fracture outside of theatre and they feel it's safe, then that's their decision, and we will do what we can to support that. Obviously, there are other considerations when it comes to giving people ketamine in the emergency department. So what are your other considerations in terms of, so there's a fracture, but what else is there? Yeah, other patients and staffing. What's NB status? Oh, neurovascular status, yes. Yeah, so so the neurovascular status, as we said, kind of comes into that. So it's safe to sedate personnel and patients. So whether the patient's safe to sedate, whether that is the right thing for that person. And again, having that discussion with the family. If you're thinking, actually, I'm worried about giving this person ketamine because of the state of the department, is it appropriate to use Entonox? Is it appropriate to use fentanyl? And that is an open question. That's not it's not a leading question. They don't have to do that. Some children will be fine, and some people will not. And you really have to be guided by the other staff in that. So we're really lucky that we've got really excellent play specialists who are ready to be quite frank with other teams if they feel that what they are suggesting isn't the right thing for that patient. But yeah, so you've got to think about personnel and patient. And from a consultant point of view, what I would say is that means if you have somebody down in a minor injuries area and you've seen them and you can see that their arm is bent and you're sending in for x-ray, it's really useful to let the doctor in charge know about that, because that means we can start preparing to answer those questions, maybe move people around, maybe send a nurse on their break earlier, so that we're ready to do that. And so it's useful to know, and if it turns out that a fracture is not right to be called after the x-ray, or that patient's not right, then that's fine, but it is better to be prepared, because all of these things do take a little bit of preparation. So I'd really encourage you, if you've got a terrible fracture that you think, oh, this needs something doing, please do let somebody senior know as soon as possible, so that the department can prepare for that. Has anybody got any questions about that or anything else that they'd like to add? Interestingly, so we always use ketamine. Does anybody use anything else other than ketamine? Just I'm asking out of interest, really. Okay, fine. Okay, and so Elizabeth, do you use morphine and Midaz for children as well as for adults, and for short procedures? Yeah, okay, yeah, that's interesting. So at the moment, Penthrox still isn't licensed for children, so we don't. I used to use it a lot in Australia, but yeah, we don't use it here. They're thinking about trialing it. I keep on forgetting how far along they are with the research on that, but they're trying to get a license and things. Yeah, so and again, so it's just in terms of, if you're thinking about using drugs, it's just about risk assessing that drug. So but personally, I wouldn't use propofol for this kind of thing, but I know that people do. But for me, that's a risk benefit that is definitely in favour of ketamine. I love ketamine. I think it's great, and I've never really had any significant problems with it. So the significant problems are theoretically airway compromise, but I've literally never seen that happen. And I've sedated lots of these children. And vomiting is quite common, so quite common afterwards. And that's just worth, again, preparing people for that, because I think they're going to get their fracture pulled and then it'll all be fine. But if the kid is vomiting loads, and obviously that takes a little bit of time. And then you have to think about dissociative hallucinations as well afterwards, and just prepare for that. So again, we have a protocol for that where we keep the child in a nice quiet place, and our place specialists go through everything with them, and they're really great. Okay, is there anything else that anybody wants to say about that? So we are, so Elizabeth has just asked if we use ketamine sedation in VSAS or in a different area. So we have in our HDU bay, we have an HDU bay that we can close off. So the thing with all sedation is that obviously you need to be prepared for airway compromise. So that means that you need to be prepared for AGP. So you need to have a room that you can do that in. So we're quite lucky that we've got 3 HDU bays and one of them has doors that we can shut. And so we'll do it in there usually. When we had to separate red and so COVID positive and COVID suspected and non-COVID suspected completely, we did actually use a treatment room for this, and we set up the treatment room with an airway trolley and CO2 monitoring to do that. So that it was safe to do that, and we had exactly the same protocol and procedure and equipment in that room as we would do in our HDU room related to ketamine. We never had to use any of it. You kind of got everything ready just in case. So we have an HDU bay that is kitted out as a resource that we do our ketamine sedation in, but we have previously done it in other places and just set up those rooms for ketamine sedation on after discussion about the risk benefit of that. Honestly, I don't know what the risk age limit is for Penthrox. I'd have to do. That would be a Dr. Google question. Sorry. All right. Okay, so these are our rules. So 2 senior doctors in departments, enough nurses, a free HCA. Remember, you've got to have somebody to plaster. Can we flex our job role? So, for example, does ACP want to be the doctor or the nurse because they're trained to do both? Actually, quite often, sometimes I'll be the nurse because I can write down obs and stuff like that. It's really important when you're kind of talking to ortho that you don't promise them anything, because you might have a red call come in and then it's no longer safe. So it was safe when you were planning, but it's no longer safe now. And the other thing I would say, sometimes they'll ring up and say, oh, we want to ketamine this patient, and it's like, you've not seen them. You need to see the patient before deciding, and they must speak to the nurse and doctor in charge. And again, it's just kind of, it's because the doctor and nurse in charge have the overview of the department that must happen, and so there's no mixed messages about who's been involved in the decision essentially, and why we're doing what we're doing. And that really helps reduce the chance of any conflicts. Okay, so this is a not bent but tender. So this is coming back to the point really, and who should be X-ray. So if the patient is in loads and loads of pain, So I had a little bit of a discussion earlier about whether or not you think about functional pain. I think if the patient's really, really tender, your default position should be to look for a fracture. And if after looking for a fracture, you're sure it's not fractured and actually there is a functional element to it, then you can kind of gently go down that avenue. And that's actually really important, because if you don't, there are, people do develop complex regional pain syndromes from minor injuries, and actually you don't want to give them that either. You really do want people who have non-medical pain to be able to manage that in an appropriate way. But if they've fallen over and it really, really hurts, it's not unreasonable to X-ray, because you might be missing something. And if they've got any point tenderness, so anybody who has point tenderness, remember, children who are saying it hurts just there, they are broken until proven otherwise. Children sometimes have, we talked about them having a psychological element to pain, but sometimes they really don't, and sometimes they're really, really chilled, and sometimes they can wander around with quite a deformed arm and be completely happy. I had my favourite story from Australia was of a 4-year-old girl who cartwheeled off a sofa, landed on her arm, said it hurt. Mum gave her some Calpol, she got up, said it still hurt. And Mum said to me, oh, I don't want to worry about you, doctor, but it just looks a bit bent. And it was bent. And this kid literally climbed up onto the couch, putting the whole weight through this broken arm, and only flinched once, but it was properly bent, properly deformed. And she had point tenderness. So that's part of my decision-making process. And you're right, Lisa, when you're thinking about psychological elements to pain, sometimes proving there isn't a fracture is part of the treatment. And again, it's thinking about this as a holistic model of care. Yes, we don't want to X-ray everybody. No, we don't want to over-radiate everybody. But at the same time, if it's equivalent as a flight to Spain, then you need to factor that in. Actually, if this is going to make them feel better, and there is a significant, there's a reasonable suspicion for a fracture, even though you think it's probably not, then actually it might make them feel better. It is obviously up to the clinician, depending on the presenting signs and symptoms and the mechanism of injury, followed by the physical examining. But I guess my point is, if you've got point tenderness and the child's in a lot of pain, then that's going to be part of your guiding thing. And if they've got none of those things, then yeah, that's fine. You don't have to X-ray them. And going back to the point, if it's not bent and it's not really swollen and it's not really painful, the chances of them having a significant fracture that you've missed are really, really slim. And the chance of you having a significant fracture that would cause them any problems by not treating it are also really, really slim. And it's just about kind of documenting that as your thought processes. And discussing it with the family, obviously. And again, according to your local protocols, I mean, we have procedures for this, just like everywhere else. Okay, any other questions about this? Okay, so buckle or greenstick? How do you decide? What's the difference? Yeah, so the greenstick goes through the cortex. So what have these kids got? Can you spot the fractures? Yeah, and a bump is a good way of remembering the buckle fracture. The one on the far right's actually got 2 fractures. I'll give you that clue. One of which is neither a buckle nor a greenstick. So the one on the far right, so they've all got little buckle fractures in their radius. The one on the far right also has a fracture to his ulnar styloid that you can see there. Can everybody see that? So hang on, if I escape this, can you see that there?
Yes, we can, Catherine. We can see that. Yeah.
Yeah. There you go. Perfect. Oh, let me get rid of this. Okay. So essentially, I don't know. So again, there's a little bit of variability in practice and how everybody manages this. So how does everybody manage their greenstick fractures? And we cast ours, but put a back sub on and then. Or, I don't know what Beb's is. Is that below elbow back sub? Aha. Yeah. So we're using soft wrap at the moment, just because it's easier, and that will probably stay. Soft wrap is a little bit like plaster, but it's softer, as you might think. Our buckles, we just use splints. Does anybody do anything different to that? No. Okay. Cool. All right. So we're kind of matching then. Perfect. Okay. Oh, my little thing is still there. So my summary of all of this stuff is very much applicable to pretty much everything. So sorry, but essentially, if you examine carefully, you're going to find what you need to find. X-ray when required. Please do consider taking photos. It really helps with the process of the patient. Again, like in an information and government safe way. But it's also about anticipating and explaining the process. So a lot of the problems that patients have in minors is because they don't know what they're waiting for. They're not sure what's going to happen. They're not sure who's going to do it, and they're not sure why. So if you're thinking something more complicated than just than just an X-ray and then home, is thinking about actually, yeah, your arm does look broken, so you probably will need a plaster from that. We'll have to X-ray it first, and then you might have to wait for the plaster. That's really helpful.